Hello again, my name is Marcos Arreta Garzón and I am student the University Catholic Santiago from Guayaquil. This time I'm going to explain to you about atrioventricular dissociation during ventricular fibrillation. Definition: atrioventricular dissociation is characterized by the independent functioning of the atria and ventricles, with two pacemakers containing one that excites the atria, usually the sinus node, and another that excites the ventricle and ectopic focus of the atrioventricular or ventricular function. In short, dissociation is a disorder in the electrical conduction between the atria and the cardiac ventricle that can be temporary, intermittent, or permanent. Nursing application: regardless of the hemodynamic stability or instability of the patient, continuous electrocardiography monitoring of the patient will be carried out, as well as control of vital signs, oxygen saturation and blood glucose determination, administration of high blood flow oxygen therapy if oxygen saturation is less than 90%, peripheral venous cannulation, and seroperfusion in the acute setting. Symptomatic atrioventricular dissociation can be treated with intravenous vagolytic drugs such as atropine or catecholamines or cyprenolide. If these drugs are not effective, a temporary pacemaker will be required.
Electrical activity within the heart determines heart rate. If this electrical activity is delayed, a slow heart rhythm may occur. People who have slow heart rhythms may feel tired, dizzy, lightheaded, or even pass out. A pacemaker is a small medical device that is placed under the skin, below the collarbone, and is used to treat symptoms related to slow heart rate. A pacemaker is composed of two parts: a pulse generator and a wire or lead. The lead is passed through a vein and makes contact with the heart muscle. The pulse generator constantly monitors the heart rate. When it detects that a heart rate falls below a certain level, it sends an impulse down the lead to the heart, which causes it to beat. A small surgery is required to implant a pacemaker, which takes about an hour. Patients are awake during the procedure and are given a mild sedative. The area under the collarbone is frozen and a small incision is made. The lead is then passed through the vein to the right side of the heart using X-ray guidance. The pulse generator is then connected to the lead, and the incision is closed. Patients will usually go home the next day. Pacemaker surgery is safe. The most common risks are bruising, bleeding, or pain around the incision. Other risks include infection, or a pacemaker lead moving, requiring another procedure to reposition it. After your operation, you will be given instructions on how to care for your incision and will be given an appointment to come back to the pacemaker clinic in a few days. You may not drive for 1 week and should not lift your arm on the pacemaker side above the shoulder for 1 month. If you have any questions, speak to your doctor or call the pacemaker clinic.
Pros and cons. Pros: non-communicable disease. Cons: symptomatic of the sinus or syncope, chest pain, general malaise. Various cases can generate in such as sinus, bradycardia, hyperactivity, or subsidiary pacemaker. If leak untreated with 24 hours, it can lead to death or permanent disability. The effect or antiarrhythmic drugs are a common case of acquired ventricular arterial dissociation. Usage applied in Ecuador. Currently, in Ecuador, cardiovascular disease leads as one of the leading cases of morbidity and mortality in the population. A mountain when find the size of the cardiac conduction electrical system, with which the indication and demand for the implantation of pacemaker to treat most of this condition is increasing. For this reason, since March 2014, the Guayaquil Dr. Abel Gilbert Ponton Specialty Hospital offers a permanent pacemaker implantation service to patients who meet criteria for their use.
Wellens and colleagues highlighted the importance of atrioventricular or AV dissociation in 1978, which later matured into one of the most trusted EKG criteria to secure a ventricular tachycardia diagnosis. Now, as a general rule, ventricular tachycardia may be confirmed once AV dissociation is present, especially when the ventricular rate exceeds the atrial rate. Not surprisingly, several wide complex tachycardia differentiation methods actually include AV dissociation as a key VT diagnostic criterion. However, although AV dissociation may be quite valuable in establishing a VT diagnosis, its absence does not rule out VT, since it's not always found or seen on the EKG, even amongst those with known VT. Now, by definition, AV dissociation is present when a self-governing ventricular rhythm autonomously subsists the atrial rhythm. Okay, so what does that mean? You have something here in the ventricles. Imagine that this is your ventricular focus that is pretty much subsisting or self-governing, taking over electrical activity of the heart. Now, classically, AV dissociation is characterized by a series of QRS complexes uncoupled from dissociated P waves. When interpreting a 12-lead EKG displaying VT, AV dissociation may be recognized as interspersed P waves that are nestled between or hidden amidst overlapping QRS complexes and T waves. If you look at this figure here, I've highlighted them. So these are the P waves that we're actually seeing in this lead V2. So notice here are two P waves nestled in between our QRS complexes, which are these ones here. Okay, so notice they're quite difficult to see, even hard to see in lead V1, but they are there in this case. And so, as you can imagine, these are sometimes even the best EKG interpreters have difficulty trying to identify these. Now, less commonly, AV dissociation manifests as a capture or fusion beats, each of which depict varying degrees to which a supraventricular impulse contributes to ventricular depolarization. In the case of a capture beat, an ideally timed supraventricular impulse seizes ventricular depolarization entirely and produces a single QRS complex resembling the patient's baseline rhythm. So what does that mean? Now imagine you have, here's your sinus node. Okay, we can say this is our SA node or sinus node. We have conduction that's coming through the atria, through the internodal pathways, even maybe to the left side, to the left atrium, through that Bachmann or interatrial conduction fibers, coming to the AV node, going through the His bundle, and then passing through. Now imagine that you have this ventricular focus somewhere here that's still going, and it's producing impulses, and you have ventricular tachycardia in this patient, but you also have a sinus rhythm or an atrial rhythm going on.
Conclusion. Atrioventricular occurs when the atria and ventricle are under the control of the pacemaker and be independently of each other. Atrioventricular dissociation is not an arrhythmia. It is the result of some mechanics that cause the independent beating of the atria and ventricle. For cause of atrioventricular dissociation includes slowing of the primary pacemaker, acceleration of a secondary atrial block, and interference. For this reason, the location of an atrioventricular conduction disorder is necessary to determine the probability and rate its progression in order to treat it properly. Thank you for listening carefully to the exposition.